Hello and welcome to this lecture. Today we are going to discuss community acquired bacterial pneumonias, and I'm presenting a case of a 66 years old man present to an urgent care clinic with 4-day history of dry cough progressing to rusty colored sputum, sudden onset of chills the previous evening, subjective fever, malaise. Originally, the man thought he has cold, but the symptoms had worsened and he barely slept at night with all of the coughing. He related that on the way to the clinic, he felt some sharp right-sided chest pain after particularly a long bout coughing. He denied any leg swelling or orthopnea or left-sided subtunnel chest pain. He also denied any gastrointestinal symptoms, no nausea, vomiting, or diarrhea. His past medical history included hypertension, hypercholesterolemia. He reported no antibiotic use in the previous 3 months. The man's chest X-ray revealed a lower right lobar type pneumonia without effusions. Let's discuss community-acquired bacterial pneumonias. And the most common cause is Streptococcus pneumonia. And the increased frequency of pneumococcal infection occur in such settings such as somebody have CHF, chronic heart failure, chronic obstructive pulmonary disease, or diabetes, or if a patient having defect in immunoglobulin productions, such as in AIDS. In these case studying in these clinical settings or in these chronic diseases, there will be more chances of pneumococcal infection. It is caused because of the variety of organisms, such as Streptococcus pneumonia, Haemophilus influenza. It could be caused because of the Moxilla catarrhalis, then Staphylococcus aureus. Then it could be caused because of the Pseudomonas aeruginosa or Mycoplasma pneumonia. So there are a number of microorganisms are responsible for the disease. Morphologically, it has been divided into two sections: anatomical, on the base of the anatomical distribution. One is lobular bronchopneumonia, and the second one is lobar pneumonia. Uh, in bronchopneumonia, actually, there will be the patchy consolidation of the lung and consolidation of the large portion of the lobe or entire lobe, defined lobar pneumonia. So when we compare bronchopneumonia, there will be more patch, like these round patches will be found. Whereas lobar pneumonia is more section. It is restricted to one section or one portion, as we mentioned that a large portion of the lobe or entire lobe defined lobar pneumonia. So we know that there are different lobes, like superior lobe, this section, middle lobe in the middle section, inferior lobe in the middle, in the last section. Then we explained them in terms of the fissures. So actually our lungs have different sections that join together to make our lung. So bronchopneumonia is more like a patchy. It may be on the lower part, it may be on the middle part, it could be on the upper part. Whereas lobar pneumonia have been associated with some section, certain lobe that can be affected. They mentioned in gross that lobar pneumonia having gray hepatization. So how can we see the gross structure? If you see this line and the lower lobe, you can see this lower lobe is more consolidated and it is more differentiated. So upper part is the normal part, where the lower part is infected side. And they mentioned that the lower lobe is uniformly consolidated. How can we see consolidation? I will show you one picture. This is a picture I identify online, and this is a bronchopneumonia picture with gross pathology. If you take a look of this picture, I just need to annotate 1 minute. Yes, this section or this section. So this section, these all sections are different, and you can see that the patch is consolidated, they are compact. And you can see this section on the left side, this one is not compacted. So the key characteristic that are found in pneumonia, especially bronchopneumonia, is that there are patches. In bronchopneumonia, the patches is all around the lung, whereas in labor pneumonia, the patches may be constrict to either lower lobe or the middle lobe. It depends upon the anatomical site. So the labor pneumonia consists of 4 stages of inflammatory response. First is congestion, and the lung is heavy, boggy, and red. That will be fine. These are the pictures that we can see the presence of inflammatory mediators. This is a normal histological picture where you can see that that normal histological characteristics of our lung consist of bronchioles. Then we have these characters we are known as blood vessels, the red color. Then this round is known as the round empty structure showing the bronchioles. Around them we found some more blood vessels, and then we found alveoli. So this is the normal histological features which consist of bronchioles, blood vessels, and then alveoli. And in our pictures that we see here, in both of the pictures, you can see this is actually alveolar septa, which is connected with the alveoli, and it is filled with exudates. So they are showing you the presence of congestion. That is why the lung will appear in the form of compacted, because the alveoli has been congested. And that is why if a person having asthma and pneumonia both, then it may worse asthma more. So that is why it is patients that are asthmatic need to be very careful with infections like pneumonia. Again, this is another picture. They're showing you the presence of a number of macrophages, a number of inflammatory mediators. So that's how I know it is difficult for you to see how it look like, but actually they are showing you that congestion that can be seen easily in different sections. So we can see that again. I mentioned this is the presence of inflammatory mediators, and this is the, you can see that the septa, and then they, because of this presence of inflammatory mediators, they occupying the space, and it appeared like a congestion. Complication of pneumonia consists of tissue destruction, necrosis, formation of the abscess. Then it spread to infection to pleural cavities, causing intrapleural fibrosuppressive reactions known as empyema. Then bacterial disseminations to different body parts such as heart valve, pericardium, brain, kidney, spleen, and joints, causing metastasis, abscess formation that leads to endocarditis, meningitis, and suppurative arthritis. What is meant by suppurative? It means the formation of the pus. So you can see the pneumonia complications can lead to the heart, causing inflammation in the heart. It can cause endocarditis. It can cause meningitis, metastasis, abscess formation, or pus formation in a number of organ systems. The clinical symptoms consist of abrupt onset of high fever, shaking, chills, cough-producing mucopurulent sputum, occasional patient having hemoptysis. When pleuritis is present, it is accompanied with pleuritic pain, pleural rift friction, and the whole lobe is radioplaque in lobar pneumonia, whereas focal opacity in bronchopneumonia, that I already discussed with you. Focal opacity mean in bronchopneumonia it appear in some patches. It is more opaque and it is in the form of patches, whereas lobar pneumonia is more radiopaque. What is radiopaque? Radiopaque, actually the word we need to see, RADIOPAQUE. So it means this word come from radiation. So when you take a look of, actually this is also a kind of opaqueness, but opaqueness when see under the x-rays. So it means in the lobar pneumonia, the whole lobe is radiopaque, the whole lobe is affected, and whole lobe is opaque, like just like when you see the x-ray, uh, when you see under the x-rays. Whereas focal opacity is actually talking about the pneumonia that occur in different patches, in different lobes, in at certain anatomical site. So what are the learning outcome of this lecture? We have discussed the causes of community acquired pneumonia. We have discussed the morphological and clinical characteristics of pneumonia, and discussed the probable complications of pneumonia, such as it can cause endocarditis or formation of metastasis abscess formation. So thank you so much for today's lecture. Hope to see you again.